Good afternoon. I'm Adam VanDeusen, and I am a PhD candidate in Industrial and Operations Engineering at the University of Michigan. And today I'm going to discuss some of my work that I've done with my advisor, Dr. Amy Cohn, on how we've used simulation to inform policy decisions so that we can improve access to healthcare. The work that I'm going to present today has been conducted at CHEPS, the Center for Healthcare Engineering and Patient Safety at U of M. This is an interdisciplinary research center that's been a really valuable part of my PhD program, especially because I've been able to mentor undergraduate and master's students throughout the course of my time here. Today, I'd like to talk to everyone about how we use simulation to inform policy to improve access to care. And specifically, I'm going to spend most of the time on a case study of gastroesophageal reflux disease, or GERD, for patients who may prefer telehealth visits versus an in-person appointment. So just to start off with a bit of background, we're going to delineate between primary versus specialty care. Primary care involves providers that provide routine care and maintain patients' health over time. So you can think about this as getting your annual physical or annual exam. Specialists are more trained in a particular branch of medicine, and specifically today we'll be talking about gastroenterologists or GI doctors who deal with a lot of diseases of the gut. Another important piece to consider is that timely access to care impacts outcomes for patients. So if we can get patients into care quicker, we can improve their outcomes. And this is really important because about a third of Americans have reported an unmet health need or delay in seeking care. So this leads to negative clinical outcomes. So they actually have things that are going on health-wise that impact them, an increased cost both to the patient and to the provider system, as well as operational burden, specifically in the provider system, but also on the patients. And we know that telehealth visits, which includes video or phone visits that were typically conducted in person, but now are being conducted over the phone or over a video conference, telehealth has the potential to improve access to care, especially for patients who live in rural areas. And these patients tend to be older, poorer, and sicker than those who live in urban areas, so access to care is really important for them. Most notably, the distance to care is a significant barrier for them. And so if we can use something like telehealth, that can help minimize that barrier. For this case study, we're looking at patients who are at the VA Medical Center in Ann Arbor, Michigan. Again, we're considering just GERD patients for this case study, and are just going to compare traditional face-to-face visits to telehealth visits. We're going to simulate patients flowing through our system and then try to ask questions like, what kind of scheduling policies can we use that allow us to understand how patients are able to get the care that they prefer? And then what other policies or system factors impact access, such as the number of providers that we have staffed or the capacity of each of those providers. When we think about GERD patients and how they interact with the healthcare system, typically they start out with what we call home treatment, which is basically them trying out different remedies at home to manage their reflux disease. So often this involves taking something like Tums or other over-the-counter medications, but at some point they may start to seek care. They may either go visit their primary care provider, their PCP, or they may go seek out care directly from a specialist, from a GI provider. If they seek care from a PCP, that provider may provide a series of appointments with increasing intensity of the types of recommendations they have. So potentially more and more impactful medications or other recommendations. And if a patient still hasn't gotten better after 4 visits, then they'll be referred to a GI provider for more intensive care. If the GI provider sees the patient a couple times and still hasn't made any progress, they'll be referred to an endoscopy for kind of a final diagnosis in case the GERD is being impacted by something like a tumor. At any of these appointments as well, patients may leave the system because they've gotten better, or they may just move away or stop seeking care from the system. And also at any of these appointments, the patients indication may be severe enough for them to be referred directly to an endoscopy. So we modeled this system in our simulation using a transition probability matrix where we have all of our current appointments that patients could be at and where they could be going next. And each of those has a non-negative probability of going from one appointment to the next appointment. And then also some probability that they'll exit the system as well. Within our simulation, we're going to have a few inputs. And the inputs that we change during our sensitivity analysis are highlighted in red, but all the values I'm showing here are our baseline values. So as I mentioned, we're comparing face-to-face versus telehealth appointments. At each appointment, patients have a probability of exiting the system of 0.16, and they also have a probability of getting referred directly to an endoscopy of 0.05. We start with 2 PCPs and 2 GI providers within our system, each of them having 4 telehealth and 3 face-to-face appointments available each week for GERD patients. We know that providers see many more patients than this each week typically, but we're thinking just for GERD patients, they see around 7 each week within the case study that we've been working in. We have patients arriving each week, about 5 of them arriving each week directly to PCP, and 7 who self-refer to a GI. And then we do include a Poisson distribution around each of those. We have a probability that patients live far from care of 0.014. This is pretty small, but this is the patient population that we're using has this distribution. And far is considered living more than 40 miles from the clinic. And this is a VA designation for near versus far patients. And within our sensitivity analyses, we also increase this quite a bit so we can see what it looks like when we have a greater proportion of patients who live far from care. For our patients who live near, about half of them prefer telehealth as their preferred modality to receive care. And for our patients who live far, we consider all of them to prefer telehealth. These numbers are inputs for now because there isn't great data yet on how the relationship between a patient's location and their preference for telehealth. And we do vary these within our sensitivity analysis as well. A key component of the simulation is the scheduling policy we're going to use. So to create a scheduling policy, we combine an in-range policy and an out-of-range policy. We have certain numbers of weeks that are clinically ideal for patients to be seen in from one appointment to the next. And we consider that time span to be in range. Usually we use 2 to 8 weeks for that in range. And then if we can't find an appointment within that ideal range, then we'll start looking out of their ideal range for a policy. So our in-range policy could be getting the first available appointment of any type. We could say the first available preferred appointment. So if a patient prefers telehealth, we'll only look for a telehealth appointment within range. Or we'll look for the first preferred appointment. And if there is not a preferred appointment available, then we'll take the first available appointment of any type. With out of range, we just look at first available of any type and first available preferred. So what this looks like sort of in action, and we can look here as an example. If we were using policy C1 and we had a patient who prefers telehealth appointments, who needs a new appointment, we would first look in range. So ideally in the next 2 to 8 weeks for a telehealth appointment, because under policy C, we're going to look for that first preferred available. If there isn't a telehealth appointment available within range, then we're going to look for the next in range face-to-face appointment. If there are no face-to-face appointments within range available, then we'll look out of range and find the first available appointment of any type and schedule that patient there. Our simulation is run in C++. We run it over the course of a year and replicate 500 times, and again, conduct sensitivity analyses. We look at metrics like patient arrivals, patients who complete care, provider utilization, lead time, and percentage of appointment preferences met. Looking at an example of some baseline, of some metrics using our baseline inputs in policy C1, we have about 300 patients who complete care. Our provider utilization is pretty high in our face-to-face appointments, but lower in our telehealth. And we have a lead time of about 3 weeks. and we meet patients' modality preferences almost 100% of the time. So looking a little bit more at results in depth and looking at how the impact of scheduling policies impact some of our key metrics, we can see that our policies where we find the first available appointment in range of any type, we only meet patients' preferences around half the time. But once we start considering patients' appointments for their preferences using a B or C policy, then we'll meet patients' preferences 100% of the time or nearly 100% of the time. Next, if we look at provider utilization, which is shown here, we can see that across all of these different scheduling policies, face-to-face utilization is pretty high across all of them. But as we start to use some of our patient preference policies, the telehealth utilization decreases. What's also important is that lead time, it does not significantly change once we start to incorporate patient preference in our scheduling policies. So this indicates that we can start to incorporate patient preference and not have a significant negative impact on something important, like the time to care, that lead time for patients. So knowing that we don't have significant differences or significant negative impacts on patients using some of our policies that incorporate preferences like B1, B2, and C1 and C2, we'll continue the bulk of the rest of our analysis with policy C1. So under policy C1, we'll also look at what's the impact of increasing the percentage of rural patients. So we start at, we have 1.4% of patients are rural at our baseline, and then we can look at what happens when it's 0, or if we increase it up to 50%. And we can see that the telehealth utilization does go up as we increase the percent of patients who live far from care. Face-to-face stays pretty high too. So this really indicates that we may want to increase our telehealth capacity. We also see that we see some small decreases in lead time for patients as we increase the percentage of rural patients. Then if we look at the number of providers who are staffed, we can look at our baseline, which is 2 PCPs and 2 GIs, and see what it looks like when we have 1 PCP, 2 GIs, 4 PCPs, and 2 GIs, and then also changing the number of GIs, so 2 PCP, 1 GI, 2 PCP, 4 GI. There's no major changes to utilization as we increase the number of providers of each type staffed, but we do have a pretty decent decrease in telehealth utilization when we have 4 PCPs. And then our most notable result here is the impact of lead time of provider staffing. When we decrease the providers, either PCP or GI, we do have a pretty big increase in the lead time for patients. However, if we increase those providers, then we do have a significant decrease. We also can look at some specific output metrics to see which inputs have the biggest influence on them. We do this for all of our metrics and all of our policies, but I've highlighted 2 diagrams here where we look at lead time under policy A1 or C1 to see what the most important inputs are. So we vary each input by plus or minus 50% while keeping all others the same to see the impact on our output metric of lead time. So we see in this case, the number of PCPs is the most influential factor under both policies. And this shows just how intertwined primary and specialty care can be, especially in this context. So more diagrams can be shared in the Q&A if folks are interested. So some conclusions from this case study are that telehealth does help to reduce barriers to accessing care for patients who live in rural populations. And we've found some appropriate scheduling policies that explicitly allow us to accommodate patient preferences, but don't have a significant negative impact on patients' experiences. And when we're considering access to specialty care, we can't forget about how the capacity of primary care impacts that as well. So some potential next steps for this work could be to expand patient attributes beyond just living near or far from care, and then also correlating our no-show probability with appointment preference. Beyond this case study, we can think about some other ways that simulation could be used to evaluate access to care. We've had some great work done in the wake of COVID-19 where we look at different policies for triaging colonoscopy patients under the reduced capacity that COVID-19 incurred. And that really helped us inform other collaborators at the VA about how they could reopen safely, but not have patients have negative clinical health impacts because they are waiting for appointments. We are also currently working on how to better understand how we can use predictive modeling in chronic liver disease care and how bringing a predictive model like that into a care pathway impacts patient access. So as we're better able to understand a patient's best care pathway, what does that do to the number of providers that we need or things like patients waiting time for appointments? I want to thank the supporters of this work, which include the University of Michigan Institute for Healthcare Policy and Innovation, and also the Michigan Program on Value Enhancement, or MPROVE, as well as the Seth Bonder Foundation and CHEPS. I'd also want to acknowledge the student research team for this work, including Michelle Chen, Pushpendra Singh, Emmett Springer, Advaid Venkat, and Nicholas Sakarat. I look forward to discussing more in the Q&A session, and my contact information is here.